We are on the cusp of an amputation epidemic across the United States due to diabetes and chronic kidney disease.
We still have about 150,000 amputations a year, and only 38.7 underwent revascularization within the 12 months before their amputation. And it gets
I don't
even worse.
understand.
Nothing prepares you to wake up with a sheet flat where your foot was. The loss and the grief that folks go through is pretty significant.
I am going to say something you really don't want to hear. We are on the cusp of an amputation epidemic across the United States due to diabetes and chronic kidney disease out of control. And that is leading to more and more people with blocked leg arteries, a complication of both, which are just not being caught at the early stages. And for those who do end up with an amputation, unfortunately, there are just few resources available. But the good news is that there are incredible people like physician's assistant Tina Godfrey Hurley, who is a godsend. And we're going to share her journey to starting less leg, more heart in just a moment. But Dr. John Phillips, there is someone else that is actually fighting for these folks who have amputations. We had him on the show recently. It was David Vino from Neuros Medical. They have that stimulator that blocks the nerve signals that cause pain and either phantom pain or residual pain from an amputation. And I was on Capitol Hill this week with David Vino and former Senate Majority Leader Tom Daschle, Wounded Warriors, Amputation Coalition, and many more advocacy groups all talking about the amputation epidemic and what are we going to do. So it's good to see that we're now just starting the conversation. I'm hoping we're not a little too late. What do you think?
Well, I mean, a very timely topic. This past week, I was given a lecture at the Ohio Foot and Ankle Medical Seminar. So, speaking to some podiatrists about chronic limb-threatening ischemia, and I had several slides on the amputation rate. And we still have about 150,000 amputations a year, and vascular amputations are the number one cause of amputation after trauma. But we're getting better, I think, at getting people to vascular specialists and then getting them testing. But I'm just going to share something real quick because this was published in Circulation in 2025. And it kind of looked at about 73,000 patients that had major amputations from 2010 to 2019. About half of them had an outpatient vascular specialist visit. So half, okay. 82% had lower extremity arterial testing, and only 38.7 underwent revascularization within the 12 months before their amputation. And it gets
I
even
don't
worse.
understand.
Yeah,
Oh,
it
no.
gets even worse because if you look at like the subsets of the population that are in they're in highest jeopardy for amputation, African American patients, they're less likely to have a vascular visit. The odds ratio is 0.87 there. And then folks of low socioeconomic means, big time. And then rural
Yep.
patients, right? I mean, so we have outreaches, but that's why it's really important to do what you do and what Tina's doing to raise awareness. Obviously, we need to prevent the amputations if we can, but then those unfortunate folks that need them also need the support. So looking forward to the conversation. Super stoked. Happy Saturday, everybody. Let's do it.
Can I add to your dark cloud? I just found out yesterday
Sure. I've got a black
I got
shirt on, so might as well.
we have to make light of. I mean, it is so sad. It's just surreal, which is why, I mean, you kind of gotta make a little light because I just can't believe here in California. I just got a call yesterday from Monet Hill, who is the wife of vascular surgeon Dr. Brad Hill, and they own Hill Vascular. We've had him on the show,
Mhm.
in Santa Clara County. And they were telling me that as of January 2026, Medi-Cal patients, which is the California version of Medicaid, Medi-Cal will no longer cover a revascularization as a standard benefit in an office-based facility. You need to go an extra step that they call TAR, T-A-R, which there's no definitive criteria for what medical necessity means. I mean, you're
Sure.
already getting the pre-authorization for the basic, but now in a office-based facility, all of our hospitals are already overcrowded. It's tough to get appointments, even with you, Dr. Phillips, right? It's tough to get in. I mean, the vascular issues are running rampant across the US. And now we're making things harder for the most vulnerable populations that you were mentioning, the African American populations, the low socioeconomic populations, the Hispanic populations. The biggest thing here is we actually cover immigrants, undocumented immigrants through Medi-Cal. And a lot of these people are at high risk of these vascular issues. And what are you doing? You're saying you're covered, but you're not going to give them full coverage for a revascularization to save your leg? Oh, it's just absurd.
Yeah, and I mean, maybe there's, I don't know, maybe there's a nuance to that in the sense of office-based lab versus an ambulatory surgical center. I don't know. I think most, I'm not an expert on this, but as I understand it, a lot of the office-based stuff is a lot of it's being moved to ASCs because there's more regulations, right? I mean, like we've had issues with OBLs, and there are good ones and bad ones, and who knows, maybe that's what it is. But the issue, like if you have, it's probably 85 to 90% reduction in major amputation if you have an angiogram. And there's also data that supports that the revascularization is much cheaper than an amputation on a number of levels. And folks that have multiple revascularizations, they do even, I mean, so yeah, the durability of what we do is sometimes is difficult, right? And a lot of patients need 1, 2, 3, sometimes procedures to kind of get them through it.
Yeah.
But there's data that supports that actually helps people. So, I mean, again, we're preaching to the choir here, but it's sad. It is sad.
But the reality is there are these amputations, and we do need help for these patients, and there is very little available, especially for the lower socioeconomic folks. And so I'm
Right.
really excited to talk to Tina about her journey to starting Less Leg, More Heart. But I think first, let's start with a moment of inspiration and lighten the mood.
Yes.
Dr. John Phillips' spectacular vascular moment of inspiration.
So, do you know who Mark Manson is? Mark Manson, he's a self-help author and a blogger. He wrote the book. I think he's got 3 books, but the one that I read most of was The Subtle Art of Not Giving a F. So anyway, it sounds like Tina is a pretty brave person. So I got a quote on bravery here. So Tina, I want you to let me know what you think of this. So he's quoted as saying, "Bravery is not the absence of fear. Bravery is feeling the fear, the doubt, the insecurity, and deciding that something else is more important."
Wow. Tina,
Tina?
oh my goodness.
Yeah, I love that as much as I love only when we repeatedly expose ourselves to annihilation as that which is indestructible found within us.
There you go. All right.
Mhm. Yeah, that's good stuff.
Dr. J, you have met your match. And coming up next, right?
She might
Right
drop
here.
me.
I was just going to say, it's a
She
good
might
time
drop
for a
me.
break. We're
Yes.
going to let her have the floor in just a moment, right here on the Heart of Innovation. Don't miss her story and her journey to starting Less Leg, More Heart. That's next, right here on KDOW. Welcome back, everyone, to the show. I promise you, this is going to be an inspiring show. It is going to actually be a lot of fun. It might not seem like it, right, Dr. John, after our dark cloud that kicked us off, but we certainly ended the first segment on a high note as you met your match, Tina Godfrey Hurley, who is a physician's assistant who specializes in vascular. And she started Less Leg, More Heart based on her own journey of limb loss. We're going to get to that in a moment, but I feel so blessed to have just met Tina, and we in one conversation decided that our organizations are going to be working very closely together. In fact, Tina, we're already working together with a patient that needs some vascular help, and she helps he's a bilateral amputee, wonderful human on this planet with a great spirit. So
I mean, it's
Tina,
awesome because like you guys, if you help one person, that's one person,
yeah.
one more than you did the day before, whatever. So like it's these small kind of like the atomic habit kind of situation, these tiny little changes. So it makes a big deal. So and a big difference too. Kudos.
We were talking before the show just that what we love about our organizations is that us being both at the top, we're still on the front lines. We're
Oh
still
yeah.
meeting with patients. We're still meeting with the doctors, and we never want to lose that, even as we continue to scale. That's one of the benefits that we want to maintain. It's one of the little bits of uniqueness that I think she and I share with our organizations. But she was just telling during the break how I didn't
Are we
even
gonna
know
let her
this
talk?
story.
We're gonna let her
Yeah,
talk. Okay, good.
exactly. So, Tina, do you want to share how you came to find us?
Yes. So my mother is a vascular patient and her physician had retired. And so, in the process of finding a new one, she accidentally got hospitalized for something completely different and decided to get a referral internally. And it so happened that Dr. Dua became her vascular surgeon. And, within a conversation, folks like us can discern whether we're in the right company or not clinically. And it
Oh
was
yeah.
very apparent within just a sentence that she just got it. She understood. She took real accountability and ownership for her patients. She talked about research. She's on the front edge of innovation. She's very collaborative. And so in that conversation, I was sharing with her about, my organization and letting her know that we're here to support amputees. And she said, "Oh gosh, you have to talk to Kim. I'm on her board." And that was the first time I'd learned about you. And so I had sent you a message on Facebook super formally just to figure out what the email was. And then we eventually circled back because we had our follow-up with her. And she goes, "Hey, have you talked to Kim?" And I went, "You're right. Let me just see where that's at." And we were able to connect that way.
Yeah, it's amazing. I love what you're doing. How did your journey begin with Less Leg, More Heart? It started with your own personal limb loss, right?
Yeah, yeah. Actually, July 28th will be my 10-year ampuversary. And
Wow.
prior to that, I was, working in hospitalist medicine as an internist for almost 10 years. And then I transitioned into vascular because I wanted to know more about what my mother was going through. And so for patients, you have a test and then you have to wait 2 weeks to talk to the doctor to figure out if this is a completely life altering time in your life. And it's a really nerve wracking waiting game for any person. And so being clinically minded, I felt even more guilty not being able to facilitate and assist her through that. So I transitioned into vascular surgery and was making amputees as a first assist in the OR and rounding on all of them. And my leg condition that was supposed to be fixable, popliteal artery entrapment syndrome, after tens of thousands of dollars of testing and trying to figure out why my foot was essentially claudicant and ischemic, we couldn't fix it anymore. And after, I think we had 9 or 10 revascularizations, I mean, all the things, right? So taking stuff out, debulking, trial and error, it fails, going back in, doing bypasses, doing in situs, then doing superficializations, and then just running out of targets, and having to have my leg amputated as a stab at, improving my own quality of life. And so the opportunity to see it both at bedside and in the bed as a patient in the same chapter, quite literally, because I was rounding on patients from an e-scooter freshly amputated back at work within 3-4 weeks because I loved what I did. And my ability to relate to patients and understand really what they were going through, and also for them to see me in such a capacity gave them a hope that their leg loss is not their life loss. And I thought that as well. So it was just the dual perspective and seeing the problems firsthand as, if a white collar affluent subject matter expert in the thing that I became, if I was struggling so badly, the everyday person wasn't going to stand a chance. And so I started Less Like More Heart in 2018 as a way to put together solutions to help bridge a patient's continuum of care when they're transitioning into acquired ambulatory disability, and also to secondarily supplement the medical system and the support that's needed for clinicians. And it's been, selfishly selfless and a way to bring all of the pain that I, have been through and continue to go through with a bilateral condition to have some purpose to it and to show other people that come through our pipeline that service is really the way to heal the best.
So how do you wrap your head around the fact, so way too much. It's actually more than being dangerous, like what's going on here. So can you share insight with our viewers, like what's going on in your head as you have this popliteal entrapment syndrome? So the popliteal artery, for those who don't know, it goes behind the knee. It's just a continuation of the pipe that comes off the aorta. And sometimes muscle bundles can get, just the way God made you, kind of form around it, and it can cause the artery to collapse and cause symptoms. And so typically that's, at least from the surgeons that I know, a fairly treatable disease process, unless if there's problems with clot forming, and then the clot can break off and cause issues downstream. But
There's actually a lot of challenges with intimal hyperplasia.
with it,
Mhm.
so like your wheels are spinning as you're being treated, and how do you come to, like, we talked about bravery as that quote. You obviously have to be pretty brave when this stuff is happening, right?
Yeah, yeah, you don't want to have to be, right? Everyone says, you're so strong, and gosh, it would be nice to not have to be. But what you find out is that the alternative doesn't change the outcome, right? It's like your narrative about what's happening to you is more powerful than what's actually happening to you. And so I visited the pity cabin and I started unpacking there, and it was awful. I didn't want to stay in that place, And so you realize that in becoming brave, it actually makes your life easier and better. The lenses that you wear, really do shape the way that you experience the world, and then that shifts your perspective. But you talk about a really important point where it's a double-edged sword, having the expertise of the thing that you are now entering, and also having so many negative outcomes occurring, and having to advocate for yourself, but not create barriers to your own care because you're advocating too much for yourself, because you do know too much. You are the patient, and that becomes a little bit of a power struggle internally, and it can do just the opposite of what you're hoping to have done. So I probably needed a lot more support. I definitely needed more support in the beginning stages, because I'd had 10 surgeries in less than 3 years, major vascular surgeries. And I was either going into a surgery.
10.
Yeah. Well, now I've had 14, but that at the point of amputation, it was 10 in 3 years. So I was either going into a surgery because it was so painful, I had no foot and I was on narcotic agents and it was terrible, or acutely recovering from a surgery, or coming out of the surgery and realizing that it failed again and lining up the next surgery. And so it was just this washing machine of pain and hardship and fear and, quite frankly, medical PTSD. And I did what most clinicians do, and you sort of dissociate from it, especially because I had to 9 to 5 help the people that were going through the same thing. And it created an internal defrag. Like, I just separated from myself, my emotions, in order to just survive. And that had a lot of negative outcomes that I didn't foresee, like the failing of my marriage, and really having to rebuild from a place of being completely stripped. It was an identity crisis, essentially. And when you're at the bottom in those places, and it's similar for every major catastrophe or addiction or loss in life, when you get to that bottom place, you get to really put your fingers on the pulse if you listen to the lessons that are being taught and redefine and reshape who you are and where it is that you're looking to go. But it is, and it was, a very, very challenging time.
And coming up next, right here on the Heart of Innovation on KDOW, we'll hear more of Tina's story and Less Leg, More Heart. That's next, so stay with us.
When your sugar runs high, it's more than a sign. Diabetes creeping in, it's a dangerous line. Pre-diabetes too, don't think it's too light. It can lead to PAD, so start the fight. Sugar's sweet, but the cost is real. High blood sugar makes your arteries feel clogged. Slow flow, it's a ticking time bomb. Catch it early, stay strong, and keep your legs on. Sugar's not so sweet when your leg is in pain. Not controlling sugar is where peripheral artery disease sets in. Got sugar? Get checked. Don't wait too late. Save your legs, save your life. Take control of your fate. Leg pain, cold feet, neuropathy too. These are signs diabetes caught you. High sugar's the link where circulation and pain left untreated. Your leg might end in flame.
Happy Saturday, P.A.D. warriors and supporters. No bigger supporter of limb loss and just the trials and tribulations of losing a limb than Miss Tina Hurley. So Tina, before we left for break and kind of through the break, you, at least in my mind, you were painting this pretty dark picture. You were in a dark place, and your leg, you lost your leg, and your social kind of network sound like that was kind of falling apart. How did you, like, at what point did you say, man, I've hit rock bottom, enough is enough, we've got to turn this around and try to get something positive out of this?
Yeah, when my husband, when I came home from a doctor's appointment 6 weeks after my initial amputation with a big wound vac on a necrotic residual limb, and I came home and all of his stuff was gone. That was the last bit of carpet that was pulled from the one remaining foot that I had. And that was the point that I decided to take a year off to heal and to get some mental health
Yeah.
therapy and to recharge and to just figure out who I am now. And that year opened up in the most beautiful way that I never could have planned. I mean, this girl that had like color coded flow charts of possible outcomes and risk mitigated with every move ended up just kind of answering. It was a paradigm shift. I would answer 2 questions to allow my life to unfold for 1 year I gave myself. And the 2 questions were, am I going to regret not doing this? And is this going to help me help someone? And I mean, that year I won the CrossFit Games as an adaptive athlete. I was a pilot for the bobsled team in Europe in 3 countries for USA. I cycled the velodrome with Olympians in OTC in Colorado.
Wow.
I trained at the Adaptive Training Foundation under former NFL player David Borbora, and I thought I was going there to get jacked and tan. And what I found was that they really worked on my head. And it was the first time that I learned meditation and sitting with my thoughts and like learning who I was and being in a room, quite frankly, with people that had much worse situations. We're talking about like combat vets that had maybe a finger left and were doing so many things that defied limitations and were showing that impossible was just sort of like a mindset. And it was such a soul recharging place. And they were a nonprofit and they serve people. And I just really put the seeds together of what I wanted to make out of this hardship and see how it could be happening for me and not to me. And that process of developing something that I could create goodness out of was really the pivotal point of the story.
And so talk about the idea for less leg, more heart, the name, its formation, and what gap you actually saw in the market, because there are other organizations that say that they help amputees.
Yeah, you know, the service model that I created, it's been very successful. And the reason is because we're intentionally vague. The only inclusion criteria is limb loss or pending limb loss. And we provide support supplies and services that improve quality of life. And we wanted to be vague and broad enough that we could be creative enough to make solutions that worked for people and the very different landscapes that their lives are, and also the potential setbacks that they have. And we're not a handout organization. Anybody can give handouts. We are a longitudinal service model of touch points that continue to identify ongoing needs and provide customized allocations to people just what they need. So it's not water out of a fire hose and then they have this to-do list and they're overwhelmed and analysis paralysis. We hold people's hand and we give them just the bits they need and check in with everybody at really regular intervals at 1, 3, 6, and 12 months the first year and every 6 months after that. So even though our metrics would show that last year we helped 103 new amputees, that's new amputees. Those are not the hundreds that are in our recurring programs. And so there's no other model like that. And the good news is this blueprint is able to be replicated across any and all, at least ambulatory acquired disabilities, right? So someone could take this model for spinal cord and take this model for neuromuscular. And, you know, I think the difference is that people need a combination of social support, of vetted resources and vetted goods, because everyone's trying to make a buck. And they need to know what next, not what's all possible, but like, what's the next thing? Show me what I need to do to lessen the burden in this moment. And also, can someone talk to my mom? Because these hopeless, helpless family members and caregivers and loved ones who are the primary support systems for these people, they need respite and they need education and they need hope and they need to be loved on. And so it's been a really beautiful and very unique model.
See, Dr. Phillips, why we're synergistic. It's amazing.
No, I mean, it's just like I have so many questions. This is like every time I say this, we need to do like a 2-hour podcast. But
yes,
we got 2 minutes left, but we'll, I think, take this to the next segment. So if I'm hearing it correctly, it sounds like you're kind of like the Aflac insurance, right? I mean, I don't know, maybe not, but like, so tell us in one column, like, okay, God forbid I lose my leg, and I go in that column and just use the resources that are available to me. And then in your column, I use your resources. Are they synergistic, or like, do you take over and I'm out of that other column? How does that work, I guess?
And coming up next, we're going to find out the answers. So stay with us right here on the Heart of Innovation on KDOW. Don't go away.
How many procedures are you willing to go through? Is it worth going through that many, or would you rather just...
That's funny. Was it worth it? Oh yeah, I have my leg, man.
Amputation should absolutely, positively, 100% never be a first-line treatment.
What an incredible operation, what an incredible Without a doubt, we're underdiagnosing peripheral arterial disease. It has not gotten the attention that it should because it is a killing disease, it is a disabling disease, and most importantly, it's a disease that we now have great treatments for. Okay, let's go to the next one.
They were going to amputate it, and I needed to consult with my family. Did I want it off here or here? You're just shocked. It's scary. I don't even know how to explain it. You're 42 years old.
We're waiting till people are at the end of the spectrum and almost beyond hope. There is good care available here. Closed minds are what we have to get rid of.
So we're back from the break, and before the break, I asked a really long-winded question to Tina. So Tina, again, I guess walk us through the process of how a patient who just lost their leg, what they're thinking, what some of the support they have without your group, and then the support that they can get with your group.
Yeah, if they're immediately post-op, even if they're a prepared amputee and they did this electively or semi-electively, nothing prepares you to wake up with a sheet flat where your foot was for that period of time, right? So the mental health piece of this is different for everybody, but it's the loss and the grief that folks go through is pretty significant while they're trying to also navigate the very challenging medical landscape and the insurance and the financial affordability pieces and home access questions and how do they, manage getting things in the home so that they can be somewhat autonomous and have dignity in their home. The pain that they're facing, right? Like how do they have adequate pain management and what types of accessibility items will they need when they get home and how are they going to get to their doctor's appointments? How are they going to drive their vehicle? What is DME and what does it cover as it pertains to prosthetics? And what are prosthetics? And what are all these components? And what's right for me? And what's a K level? And a lot of questions, right? And so
there's no handbook. You don't get a handbook,
and
right?
There's some resource guides and things too, but gosh, tell somebody that's just been through significant trauma that has an 8 or 9 out of 10 pain to sit and read a pamphlet and see how that goes. And most of the people that they've probably seen or heard about that have limb loss are chronically comorbid geriatric folks that are sort of not zestfully living. And so their idea and concept and image that's painted of their life is, it's kind of like life loss is what they're feeling and being a burden on other people. So without the support of a network that can provide, that mentorship and that advocacy to helping them understanding what is going on medically and understanding what tests or things that they should advocate for or what devices or supplies they need, it's just very overwhelming. And sometimes they buy things they don't need, or sometimes they go without, or they try things they shouldn't and they get hurt and readmitted. An organization like ours, it's pretty streamlined and they can just submit the amputee in need form, on the contact section of our website. They get a really prompt intake, a 45 minute to 2 hour conversation with a team of clinical people that have really significant interests in the full picture of their life, their medical, their social, their economic, their financial, all of the orbs, so that we get a good snapshot. And then we provide specific support, supplies, or services that benefit them in that moment, with the idea that this is a marathon and we don't want to overwhelm them. And then we check in with every person. So we say, here's what you should do this week. You should, get onto healthcare.gov and get a better insurance with DME coverage and talk to a healthcare broker to figure out if what's in, your network and what isn't. Make sure that you get a pain management specialist and get that consult going now while you're in the hospital before you get out. And hey, have your social worker call us before you're discharged, because we want to connect with some other resources that can help outfit your bathroom and make sure that things are at your home before you get there. And we got this gift card from your local grocery store that does curbside pickup, so your family doesn't have to worry about that. And you shouldn't be cleaning your house for the first few months, so we're going to send a home cleaner to your home for every 2 weeks just to make sure things stay tidy. And it's also another second set of eyes on that person in their home. And hey, what's your A1C? Do you have a doctor's appointment coming up to get another one done and make sure that your blood sugar is regulated? How are your teeth? Can you even chew food that's healthful? Why don't we start to work on that for you? So we take their whole life and we try to optimize the points of control and help them understand how they play such a critical role in that. And the idea and the outcome that we're looking for is for more people to feel like an active participant in the direction of their care, so that even if bad things happen, and they oftentimes do, they don't have the regrets from not knowing and not having done, or not, being facilitated through the process.
And are these clinicians that are volunteers, or are retired clinicians, and they in their spare time you send them these folks and divvy it up to say, hey, you're with this person, you're with this person, kind of thing? Are you getting that many inquiries, or is it that's manageable?
We've served 2,100 amputees, so we have a pretty significant volume. We have a team of 10 people on our beneficiary intake or beneficiary relations committee. And so the lead intakes are done by 3 specific people. One is a 40-year retired nurse. Another is in the healthcare space as a like a counselor that manages psychology and pharmaceuticals, and is an amputee herself. And then another one is also an amputee herself that had a really wild clinical journey and essentially has an undergraduate degree at this point in medicine. But then all of the follow-ups are divvied up between most of the people on our committee are amputees. So they've been through it.
Why wouldn't somebody use you? And I guess that's a leading question to what are the barriers to getting in front of people who have an amputation or who potentially are, have an impending one?
Yeah, we're really word of mouth based, and we have some referral partners. We let it trickle in organically. So when we get larger funding, when we're working with several $1 million and we need to actively, or we get certain grants that we have to spend this money by the end of the year, the outreach will primarily focus on rehab institutes, prosthetists, and amputating clinicians. And if those 3 are covered, and we have partnerships with a lot of other organizations, including Global P.A.D, that's really the referral process.
Do you have a story that stands out, as we head into the end of this segment, that still just warms your heart every single day? Someone you've helped? Yeah, actually, every day I leave, I touch a horseshoe handmade cross that was given to me by an amputee whose life we totally overhauled. His name is Jeremy. He lives in Texas. He is the feature story on our website. If you visit lesslegmoreheart.com, it's on that first page. It's still one of my most heartwarming stories. I had gone to a bow shop down in Texas, and I had met with the owner, and I said, hey, listen, if any amputees come through here and they don't have funding for recreation, and I think that is an important piece of quality of life, send them to me. 2 days later, talking about divine intervention, 2 days later, he called and said, hey, a guy just came in with 3 children and he couldn't shoot with the kids because he hardly had enough money for the kids to be able to participate. So he connected me with him to initially maybe grant him some range time. And his entire socioeconomic status, his lights were about to be turned off. He had blisters all over his prosthetic that was 5 years old. His backstory was that he was a public servant. For 20 years, he was a police officer. He went to Katrina to be a volunteer, and in the waters of Katrina, he got significant blood clotting issues and lost his leg. And his wife of 27 years, as he was trying to recover from that surgery, left him while they were adopting her grandchildren who were suffering from neglect. She just walked away. So he went through with the adoption, and he adopted all 3 of those children. And at the complete dilapidation of his life, his health, his world, he kept those kids safe. And coming up next, right here on the Heart of Innovation, we're going to find out how Tina and her team helped him to get his life back and to help those kids. So stay with us right here on KDOW.
Your type of condition is called critical limb ischemia. It's the most advanced form of P.A.D. or peripheral arterial disease.
Every 4 minutes, there is an amputation in this country due to P.A.D. and diabetes. We also know that 85% of these amputations are preventable with early intervention.
It's a flip of the coin. Patient prognosis is tied to whether or not they are referred to a true expert in the management of peripheral arterial disease.
Do you know if your physician is an experienced CLI operator?
When you're in the hospital dealing with doctors and stuff, you figure they know what they're talking about.
The skill level varies doctor from doctor and hospital to hospital.
Patients with limb threat are in constant fear. The depression that someone experiences after they lose a limb is equivalent to those of losing their spouse of 40 years.
I was stuck in a wheelchair close to 2 years, and my husband had to quit work.
I didn't know what to do at this point because we had had nothing but infections and hospital stays and infections and hospital stays.
And they took one toe, another toe, and then it was another toe, and then half his foot before he was even diagnosed with P.A.D.
And all I heard was, what are we doing here? Just cut it off. And I pulled the curtain back like, are you kidding me?
Do you really want to go
through all that.
That's crazy. That's insane.
The protocol is to send them to amputation. Always, always, always get multiple opinions.
We do have options.
We need to listen more to our patients.
If you're going to chop off their leg anyway, why not just let someone else try?
This is the progression. First comes the wounds, and then comes an amputation. And I wasn't going to accept that.
So that's what it's like to try to save a leg.
Okay, Tina, we're back from the break. We've got 3 minutes and 30 seconds. Finish the story about Jeremy as we're trying to lift our jaws back together because it sounds crazy.
Yeah, so everything was just falling apart. And, you know, most people would have just given him some range time, but we took him through the whole process and really looked at all of the things, and we're able to keep his lights on, get home modifications done, get his kids' school supplies, work with the mayor, got him a gym membership, a new leg, and got him dentures so he could actually eat healthful food. And we didn't realize at the time, but he shared with us after that he was pretty actively suicidal, and that this likely changed his life. And so the gift he gave me, he used to work with a lot of metals, and neuropathy is really hard for him now with his hand dexterity. But he made me this beautiful cross out of horseshoes, and still to this day, all the places that I move, it's right next to my door, and every day before I leave, I touch that.
Oh my gosh, that is such a beautiful story. And with all of those, is it funded, or do you just give a call to all of these local places and say, hey, it's a donation, can you help this patient?
That was largely a community outreach effort. At that time, it was early in the organizational history, and we didn't have big pockets. So it was me going to places, sharing the story, and just begging with tears in my eyes for anyone to help rally around this gentleman. And we got it done.
So real quick, you glossed over all the athletic achievements you had and have done and are probably still doing, but you talked about CrossFit and winning the games. What is the hardest CrossFit move to do when you have a prosthesis, and what's your favorite move?
Yeah, I think anything with like weight on you while you're running or moving is hard, especially like squatting low. So like a snatch where you have to pull the barbell up and then squat underneath it quickly. That's pretty hard. And then my favorite is anything on the rings, kipping pull-ups or kipping muscle ups on rings are my favorite.
Can you do a full? You probably could, right? A full muscle up. That's holy cow! Like, folks, that's wicked. Like, that's really, that's super hard. Come on.
Well, gymnastics.
But still, that's awesome. That is awesome. So how can folks get in touch with you? Your website?
Yeah, lesslegmoreheart.com.
Thank you so much, Tina. We really appreciate you being here with us. Make sure you do visit lesslegmoreheart.com. And if you want to watch a replay of the show, you can definitely go to youtube.com/the @ the way to my heart, and have a great week, everyone.